And tonight we're going to be talking about men's sexual wellness. I'm a urologist with the urology group in Greater Cincinnati, Northern Kentucky. I've been in practice for over 30 years now. And for a large part of my practice, I've been specializing in men's health or men's sexual health. So tonight we're going to give a brief overview of some of the issues that we deal with, and then talk about some of the potential treatment options. I'll try to keep the talk around 30 minutes, and then at the end, would answer any questions if there's any questions out there. So why talk about sexual wellness, and what is the importance? And I think it kind of breaks down into three different categories. One is physical improvements with sexual activity. The other is more psychological. And I think the third most important is what it does to relationships. Studies have shown it improves heart health, reduces stress, but you can go for a nice run and probably achieve the same thing. Psychological benefits, it's been shown to decrease anxiety, depression, stress improvements, things like that. And again, those are important, obviously, but there may be some other modalities you could choose to improve those factors as well. To me, I think the biggest thing is what it does for relationships, which is, intimacy improves communication. Communication helps resolve conflicts, and you just get closer to that person, you trust that person. And I think that's really the biggest thing that we try to achieve with sexual wellness for both men and women. This slide just kind of goes through and talks about the frequency of the issues with sexual health. And I think that used to be more of an issue. I'll tell you, today, I have people come in from 18 to 85. And I think there's so much out there, with the advent of oral medicines like Viagra, with these low testosterone clinics, that I think people are pretty aware that there are treatments available. So I think we're seeing more and more people coming in for discussions on these treatment options. The list of topics on the right, again, what we'll address is low testosterone, which again is super common. Probably I see more people in my office for low testosterone than anything else. Peyronie's disease, we'll talk about premature ejaculation, and finally erectile dysfunction. So low testosterone is a huge issue in our practice, very, very common complaint. And the issue with low testosterone is that we know why men's testosterone goes down with age. Testosterone is produced predominantly in the testicle. There are 5 enzymes that convert cholesterol to testosterone. And with age, the activity of those enzymes decreases. The cells that produce testosterone diminish with age. So we know why testosterone goes down. So the big issue is, number one, can we treat it? Which we can. Should we treat it? Are there harms associated with the treatments? And then finally, what should you expect in terms of the treatments? When you look at the signs and symptoms, people will look at these things and say decreased energy, increased body fat, reduced libido. Men come in and say, of course, I have all those things, feeling depressed, things like that. The issue is that those symptoms have many different etiologies in terms of what can cause those things. And certainly low testosterone can cause or contribute to some of those symptoms, but it can be many other things besides low testosterone. So when men come in to see me, many times they've already had a testosterone blood test at their family doctor. And I tell those men, look, I know I can do something to raise your testosterone, but I really don't know for sure if any of your symptoms are going to improve. It turns out the most common symptom that's improved is libido. And then erectile dysfunction is pretty close. You can definitely get improvements. We used to think it wouldn't do that, but low testosterone testosterone improvement can also definitely improve the ability to get erection in some men. Not everybody, but things like energy, depression, bone density. It might help those things, but it's trial and error. We try it. I have some guys that we get their numbers super high and they just say, I don't feel any different. And we probably just say, look, you probably shouldn't take it then. There are many different ways that we administer testosterone. So again, if you came to see us, we would want to get a profile of blood tests to check not only your testosterone, but some other hormones that are involved with the production of testosterone, a few other things. And on this listing here, we use a lot of topical agents. So a topical is you wake up in the morning, you take a shower, you put something on your skin. Now, because testosterone is considered it's normal for your testosterone to go down as you get age. Most insurance companies do not pay for testosterone replacement therapy, and that certainly can be a factor. Topical testosterones typically cost about $1 a day. The biggest risk of testosterone replacement therapy is something called polycythemia. That's where your blood gets too thick. And that's why if you look at testosterone replacement therapy, there's a black box warning from the FDA this may cause sudden cardiac events, including death and stroke and things like that. Now, it usually doesn't cause those things, obviously, but you do have to monitor your blood count. And so topicals we like because the chances of it doing that with a topical is literally less than 2%. Oral medications, there's a very good oral medication now available that we prescribe actually quite a bit. You take usually 2 pills in the morning, 2 pills at lunch, very low risk profile. It's a new medicine, which means it's a little pricey, but we certainly use quite a bit. Nasal sprays we hardly ever use because they have such a short half-life. You have to administer them so frequently during the day. Patches, again, have sort of fallen by the wayside. They just don't really work that well. We certainly do pellets and injections. So a pellet would be, you would come in typically every 4 months, get these little pellets inserted under your skin. Takes 10 minutes. Not a bad way to go. And then injection therapy is where we would teach you or your partner how to get a shot of testosterone. Can be as frequent as twice a week, once a week, every 2 weeks, about as low frequency. So all of these treatment options are available. They all have their pros and cons, and we use all of them in our practice. Again, just to summarize testosterone, what I tell people when they come in is, I know I can raise your testosterone, but I have no idea if that's going to improve any of your symptoms. And so it's trial and error. Peyronie's disease, we'll just kind of talk briefly tonight. Basically, it's curvature of the penis. So there's a slide that we're going to see a little bit later that shows how normal erection works. But inside of the man's penis, there's 2 cylinders. And these cylinders, when you're sexually stimulated, fill up with blood. And like a balloon, these cylinders expand in both diameter and length. Peyronie's is usually collagen deposition or scar tissue that occurs on the surface of the balloon. And therefore, when the balloon expands, you get a non-uniform expansion. So one side expands, one doesn't, and hence you get a curve. Peyronie's occurs at about 6 to 8% of men. Peyronie's was a physician to King Louis XIV who wrote a paper on this in the 18th century. So it's been described for centuries. We do have treatments for it, and it's something that I see quite commonly in the office. The biggest issue that people get is curvature, but they'll also get a bottleneck deformity of the penis with erections, loss of length, penile pain typically occurs initially, but almost always resolves with time. I would say the majority of men come in because of curvature, which is making penetration uncomfortable with both the patient and the partner. And with that, we do proceed with some testing. Typically, we do a penile Doppler ultrasound, give an injection that promotes an erection, look at the scar tissue, look at the curvature, look at the erections, the blood flow, and then come up with a treatment option. And this picture there describes, shows what the curvature with the fibrous plaque. And this curve is what we would call dorsal, which means it's kind of bending up, and that's about 80% of the curves. There are traction devices available. There's a wide opinions on how well they work. They used to be covered by Medicare. They're no longer covered. You can buy them for $150. I've seen them be $550. And I'm not sure there's a huge difference, but it's certainly something that you can try. There really aren't oral medications. I mean, there's things that have been tried, like vitamin E in the past, something called L-arginine, which is a vitamin or supplement. There's really no good data that says that they do much. There is an injection agent called Xiaflex, which we at the urology group were involved with the clinical trials on Xiaflex back in 2007. So I'm very well familiar with this medicine. It's an injection that's done in the office where we inject the drug directly into the plaque. Usually you do it twice and then you wait 6 weeks, do it twice again. You can do up to 8 injections. And the results in Xiaflex are wide, meaning some people get improvement, some people get no improvement. It's not the cheapest drug in the world. So certainly it's an option. We offer it. And if the insurance pays for it, you're not going to, break any bridges. You're not going to, if it doesn't work, you can certainly go on to do anything else. I do a lot of surgery for Peyronie's disease. And there's a couple of different surgeries that we do. I would say the most common is we just make a little incision on the opposite side and then make a typical scar on that side. And while it doesn't maybe improve all the symptoms, it almost always results in a straight penis. It's pretty simple. It's a 30-minute outpatient operation with very, very low risk. And so it's certainly something that we can offer. Again, these are quality of life issues. So patients come in, we do the ultrasound, we do the exam, and I sit down and say, look, here's what the treatment options are. And you know what another option is just doing nothing and seeing what happens. You can get some spontaneous improvement with Peyronie's disease, up to about 10%, but sometimes it actually can get better on its own. Premature ejaculation is actually probably the most common sexual dysfunction in men, occurring probably 30 to 40% of men at some point in their life will have some degree of premature ejaculation. The actual definition of premature ejaculation would be having an orgasm 1 minute or less after penetration. And usually this is something that's it's typically acquired, where they didn't have it and then suddenly they develop it. Occasionally it's a stress in their life, maybe a new relationship, but obviously it can be pretty traumatic to relationships and to men altogether. It's not the easiest thing in the world to treat, and we'll kind of go through some of these treatment options, but a lot of times, again, guilt, anxiety associated with that. And, I see 18-year-old guys coming in with this, or, all ages, basically. There's some behavioral modifications that you can try, things that you can look up, but we give literature on what's called stop-start techniques, squeeze techniques, things where you come close to an orgasm and then you back off, and you learn how to control that escalation basically on your own. Medications are used, predominantly antidepressants, believe it or not. And that's because we know that in our brain, there are these neurotransmitters that are involved with regulating what's called the ejaculation set point. And we know that serotonin is an inhibitor of ejaculation. It turns out that these antidepressants, which are called SSRIs, which we use Prozac or Paxil or any number of these, promote serotonin in the brain, which it turns out causes delayed in ejaculation. In fact, another complaint occasionally that I get from men is I can't ejaculate. It lasts too long. And the first thing I ask them is, are you on an antidepressant? Because that is the number one side effect. So we use that side effect at these drugs at very low doses to try to help improve premature ejaculation. Some tramadol, which is a drug used for pain medicine, can also be used. All these are off-label drugs or off-label uses, but we use them all the time. Typically, the doses we use for the antidepressants are very, very low, so they don't really have a lot of side effect profile. There is a drug that you can use as needed. Excuse me, but most of these are best used if you just take one every day. Finally, topical therapies for premature ejaculation. That would be trying to use a condom. You can use lidocaine topical creams that you apply before you're sexually active, can play a role. And the honest answer is usually we use a combination of these techniques. We use behavioral techniques, medicines, and topical agents. And usually we can, improve the patient's quality of life and they're, satisfied with the results. So we'll spend the last 15 minutes now talking about erectile dysfunction, which is probably I probably see more people with low testosterone, but end up treating more people for erectile dysfunction. This slide just kind of tells us that it's a very, very common complaint, affects many men. As men get older, the percentages go up with time. And that's because, as we're going to talk about, a normal erection involves blood flow. So any factor that's going to diminish blood flow, and many of these things occur with age, with increase in atherosclerosis or scar tissue of the blood vessels, is going to improve or is going to increase the amount of erectile dysfunction as well. It used to be that I think a lot of men didn't come in for treatment, but again, with the advent of Viagra, with the ads that you see on television now, I think men know that there are treatment options available. So, we certainly see a lot of men come in and at least discuss the treatment options. Again, it's a quality of life issue. When men come to see me, we talk about it. We go through some, preliminary testing, and then we just talk about the options, treatment options, and pros and cons, and we'll go through that briefly. But another one option is to do nothing. So this is a nice slide that just kind of goes through and talks about how an erection works. And if you think inside a penis again, there are two balloons. Inside these balloons is smooth muscle and blood vessels. And so when a man is sexually stimulated, of course, it starts in the brain. And then from the brain, there's a pair of nerves that go down to the penis. Now, unfortunately, those nerves run right next to the prostate. And that's why, as we'll talk about in a minute, any treatment of prostate cancer, surgery, radiation can affect those nerves. It can also affect blood vessel, but it's usually a nerve injury. When the nerves stimulate the tissue in the penis, basically it's smooth muscle relaxation. And when the smooth muscles around the blood vessel relax, you get increase in blood flow. Inside of the penis, there's these smooth muscle. When it relaxes, I say these little lakes these little ponds turn into lakes, and the penis fills up with blood. The covering surrounding these cylinders is made of an elastic material, again, like a balloon, and you'll get an improvement or increase in diameter and length of the penis, and voila, an erection. So basically, you need mostly good blood flow. You need an intact nerve that connects the brain to the penis, and definitely testosterone can play a role as well. So common causes of ED, if you look at the top number, 70% poor health, we think of poor health as blood vessel disease. So any diseases that affect blood vessels, so that would promote, let's say, heart disease. Diabetes can affect blood vessels. So diabetics often have trouble with erectile dysfunction, not only because of nerve injuries, but also blood vessel injury. And then anything that you would consider that you think of associated with heart attacks, stress, smoking, obesity, poor diet, high cholesterol, all of those factors affect blood flow. All of those factors, therefore, are going to contribute to erectile dysfunction. Other causes that I briefly mentioned are nerve injuries that we cause as urologists from our treatment of prostate cancer, pelvic surgery because these nerves are going down in the pelvis, radiation because it affects the nerves and also can cause scar tissue of these balloons inside the penis. Low testosterone affects the tissue inside of the penis. And so that's why certainly promoting testosterone can also sometimes help erectile dysfunction. So what do you do? How do you try to improve your overall health and reduce the risk of erectile dysfunction? Just the things that we would commonly think of, right? You eat well, you exercise, you keep your weight under control, you limit your alcohol, smoking, etc., stress. Obviously, prostate cancer is going to affect you, and that's just something you can't help. Genetically, that's a big issue, but a lot of things you can do to help decrease your risk. A very common question I get then for men who will come in who have erectile dysfunction, and they'll say, "Hey, if I quit smoking, if I lose weight, can I somehow improve this?" And the answer is yes, to a point. Sometimes you can, sometimes you can't, but we certainly promote all of those factors as well. I think we all know about oral medications. Viagra first came out, I think, 25 years ago at least. Viagra, interestingly, came out for the heart. So sometimes people come in, or men come in and say, "Well, my wife's worried about me taking Viagra. She thinks it's going to hurt my heart." It's just the opposite. Viagra is good for the heart. It was going to replace nitrates, or that you take nitroglycerin for chest pain. So it just turned out that the men who were taking these drugs during this trial just happened to say, "Hey, I'm getting better erections," and that's literally how the drug became available. The good thing about the medicines today, you actually don't even have to see a doctor. You can get these medicines online. But the biggest thing is they're pretty inexpensive. Most of these drugs today should be $1 or less in cost. And there really is no consensus whether sildenafil or Viagra or Cialis or any of the ones are any better than the other. It's just sort of trial and error. There is a daily Cialis or tadalafil drug that some men like to use, where you don't have to think about it. And all these drugs are readily available and today fairly inexpensive. The side effect profile is pretty low. Less than 5% of men will not take the drugs because of side effects. But occasionally you'll get that patient. And occasionally you'll get a patient who has a heart condition or something that can't take the drugs. But those are super unusual. Vacuum devices. Remember, the penis fills up with blood, and that's how men get erections. So a vacuum device is something that would help facilitate the blood getting into the penis. Once the penis is full of blood, there's a band that slides off at the base. The vacuum device comes off. And, it's something that certainly we offer. Again, Medicare used to pay for these. They no longer do. They're not crazy expensive. The biggest issue is most men do not like them. They don't work great. The cylinders that fill up with blood are typically twice the length of your penis. And so with these devices, you get something called pivoting, which it's only erect from the band from your skin on out. And it's just not really a normal erection, I would say. So while it's available, while you certainly consider it, it's rare that men say, "Hey, I really like this vacuum device. I'm just going to stick with it." Injection therapy is something we use quite commonly. If you're in any major metropolitan city, you'll hear ads on radio or television about, men's erections or men's sexual health, and we guarantee this is going to work. And they're using injections. And injections basically are a drug or combination of drugs that are injected into the penis, which cause smooth muscle relaxation. So remember, originally we talked about the brain, the nerves going to the penis causes smooth muscle relaxation. That's exactly what these drugs do. And you don't need a brain and you don't need the nerves, and you just need a penis with intact blood flow. What's good about injections? They work about 80% of the time when pills don't work. So they usually work. Not all the time. They're fairly spontaneous. Once you do the injection, you typically will get the response within 5 or 10 minutes. Most men are pleasantly surprised at how little discomfort they'll get with an injection. It's a very small diabetic type insulin needle. We teach them how to do the shots. There's a very wide dose range of shots. And so it's not like there's one shot, one size fits all. Typically, what I say is we're looking for you to get an erection that would last anywhere from 30 minutes to 2 hours. And again, about 80% of the time, we're actually able to achieve that. It turns out that far less than 80% of men who do injections will stay on injection therapy, for mainly reasons such as I don't like the lack of spontaneity. I get variable results. Sometimes it works, sometimes it doesn't. We get very frustrated. We travel a lot. It's just a real hassle, taking the medication with us as we travel. But I always like to try people on injection therapy. I've had guys who have been doing injections for 10 plus years and are very happy with it. Not that expensive. Typically, you're looking at $5 or less per shot. These are made by compounding pharmacies, typically, that are readily available and can be shipped right to your house. So, I always like to try injection therapy, but with the caveat that there's another treatment out there. But it's certainly something that we try to offer to almost every man in my practice. Low intensity shockwave therapy is something that we've offered for probably 5 years, but has been around the world, around the country for over a decade or 2 decades perhaps. And the premise with shockwave therapy is you're stimulating what's called stem cells, which are inside of our body and also inside of a man's penis. And with the stimulation of these stem cells, you're going to create new blood vessels, and you're going to improve the blood supply in the penis and to the penis. Shockwave therapy basically works best for men who say, I like Viagra, I just don't like taking it. Viagra works, I just don't like taking it. Or Viagra almost works. Or sildenafil gives me a headache, but it works. So men who have mild to moderate erectile dysfunction would be a good candidate for shockwave therapy. If you get to the point that you're doing injections, that the pills don't work, typically you're not a good candidate for shockwave therapy. If you'd had radical prostatectomy and as a result of that have a bad nerve injury, typically not a good candidate for shockwave therapy. The other issue with shockwave therapy is it's not covered by insurance. And typically it's like around $2,000 for the treatment plans, for all the treatment. But the honest answer with that is, look, we'd have to look you straight in the eye, which we do, and say, I can't guarantee it's going to work. And if it does work, I can't guarantee how long it's going to last. But it's certainly out there. There's different modifications they're looking at the different technologies of different shock waves. And I think it's only going to become a treatment option that's going to increase over time. We're going to look at a brief video now. I think it lasts just under a minute on shockwave therapy.
Diabetes, heart disease, being overweight or lacking physical exercise, and being over a certain age, although it can happen at any age. A lack of stiffness downstairs often stems from 2 physical causes. 1 is a restriction of blood flow into the vessels needed to create an erection, and 2 is a lack of tension that results in the blood escaping back into the body. Extracorporeal shockwave therapy, or ESWT, is a therapy in which short pulses of focused shockwaves with a very low intensity are directed at the penis. New blood vessels are formed, which might help to increase blood flow, and this may also result in an improved ability to get and maintain an erection. The therapy consists of several sessions and can be repeated if necessary.
Okay, great. The last treatment option we're going to talk about, and to finish up the talk tonight, is placement of a penile implant, penile prosthesis. And, one of the things I like about men who come in to see me with erectile dysfunction in particular is that one of the treatment options will definitely work. And we go through them. We do oral medications, we do testosterone replacement therapy, shockwave shots. If none of those work, a penile prosthesis or an implant will work. And while it's not maybe exactly the erection you had when you were 18 years old, the patient satisfaction for these is pretty good, 80 to 90%. So we're going to talk a little bit about penile prosthesis, how we do them, what we do, what it involves, and things like that. There is a little video that we're going to see as well. But basically, remember those cylinders that we talked about that fill up with blood? A prosthesis is something that we put, or cylinders that we put inside of your cylinders that instead of filling up with blood, fill up with salt water. And it's a device that will show the video, I think, explains very well. It is a surgical procedure, but typically it's done as an outpatient. Typically it's about 1 hour operation. I would say the recovery time is, 1 month in terms of, hey, can I start pumping this thing? It takes a month or so to start really activating the pump. And then, but the honest answer is I tell people 3 months. It's going to take you 3 months before you're going to say, man, I like this thing. I'm glad I did it. I would do it again. I tell people, for me, I've done these, for so long. The success of the operation is not me doing the prosthesis. The success is the patient, the person, the couple saying, I like it. I'm glad I did it. I would do it again. And it turns out that's about 80 to 90%. Not 100%, but it's pretty good treatment option for something that's, typically failed a lot of the other treatment modalities. What are the risks? The risks are really pretty small. I mean, the biggest thing we worry about is infection. But today, with the types of materials that are used, the antibiotics, the protocols we use, typically you're going to see infection rates 2% or less. Device failure, it is a mechanical device, so it can break. And typically when it breaks, you get a crack in the tubing somewhere. The salt water, which is used to inflate the cylinders, leaks out. But at 10 years, 85% are still working well. So if it does fail, there's no medicine that's going to resolve that. You do have to go back, take it out, put another one in. And it's certainly something that we do. In fact, the oldest patients that I've ever had prosthetic surgery in their 80s are all men who've had prosthesis. They quit working, they get a leak, and they want it replaced. Other risks, typical surgical risks, they're all just very low. Again, for a group like our group, with the doctors that we have that do this type of work, we're all trained. We all do a lot of them, and the risks are all very, very low. Now we're going to see a little video and on an inflatable penile prosthesis. And I'll kind of narrate this just briefly. But basically, there's 3 parts to it. The cylinders that go in the penis, the pump that's in the scrotum, and then a reservoir that holds the salt water. So in this diagram, you're showing the reservoir. The fluid is, in this case, blue, but it's just salt water. The cylinders go in the penis, the pump in the scrotum. And when you want to be sexually active, basically you squeeze the pump. And by squeezing the pump, you're transferring the salt water from the reservoir into the cylinders. And like your normal cylinders, these cylinders expand in diameter and some expand a little bit in length. To deflate it, you squeeze a little release valve above that button, squeeze your penis, and the fluid goes back in the other direction. One of the things that I always talk about with a prosthesis is what would you anticipate in terms of penile length? And basically that is, you would expect if you take your penis and you stretch it out, that's typically the length that you would expect with a penile prosthesis. So you definitely talk to men about that, because you won't get the length that you did, when you were 18 years old, or, typically, maybe even with a normal erection. Typically, interestingly, insurance often doesn't pay for oral medications, doesn't pay for injection therapy, doesn't pay for shockwave therapy, but it does pay for penile prosthesis, at least now. And I think that's because, if you see a huge number of patients that present who said, yeah, I'd take a pill, you see less men that would say, yeah, I'd like to do a vacuum pump, or less men that do injection therapy, and even less that do penile prosthesis. But typically, Medicare, insurance companies do cover penile prosthesis. So I think that's going to conclude my talk tonight. And I'm going to look to see if we have any questions and try to answer those questions. This is a question. I have metastatic carcinoid tumors of my abdomen, improving serotonin. This is going to be a complicated question. Might this excess serotonin achieving orgasm? I would say almost 100%. If you have excessive serotonin levels you're going to have in your bloodstream, that means you're probably going to get excessive serotonin levels in your brain, but there is something called a blood-brain barrier. So this is a tough question for me. If you're doing oral medications and oral medications aren't effective and you're a candidate for testosterone therapy, that's what we do. So if you would come in and see us, we would check your testosterone. And if you're a candidate for testosterone therapy and the pills aren't working great, we would try testosterone. But if that didn't work, certainly injection therapy would be a great option. And the drugs that are used for injection therapy are only in the penis. You really hardly get any side effects. And again, they don't work 100% of the time, but certainly that would be a good option for you. How long does shockwave therapy typically last? It's done weekly. And actually, when you're there getting the treatment, I think it's like 30 minutes or less, but it's not a long period of time. They do a series of weekly shockwave therapies. But if it's something you're interested in, if you reach out to the office, we can actually send you information that goes through this in more detail, and also even have someone reach out to you in person to contact to answer all those questions. Why do Cialis and Viagra lose their effectiveness over time? Basically because what those drugs do is help you maintain your erection. So those drugs work really well in someone who says, I get an erection, but I lose it. I just can't help maintain it. Those are the best candidates for Viagra. It's really only working mostly on the receptors in the penis. So if you have a nerve injury, it's probably not going to work. If you have issues with blood flow to the penis, probably it's not going to work. And that's why it loses effectiveness. But again, typically in patients like that, we would check testosterone and we would add testosterone to the oral medications. If that didn't work, we would try injection therapy. And if that didn't work, we would try penile prosthesis. Another last question. Looks like I have Parkinson's. Any issues with that? Not really. I'm not aware of any contraindications with Parkinson's with the oral medications. Now, when it gets to be doing, let's say, a vacuum device that requires a certain degree of manual dexterity, as do shots, as does the use of a penile prosthesis. But I've had patients come in with their partners, and their partners are obviously active participants in this endeavor, and they're usually happy to help assist with either an injection therapy or inflating and deflating a prosthesis. How long do the effects of shockwave therapy last? Good question. And the answer is we don't know. So if you come in and you decide to get shockwave therapy, you just have to realize that A, it might work, B, it might not. It might last, for years, but typically it doesn't. I mean, typically, even in the best treatments, when you read these reports, you're looking at something that 3 to 5 years you would have to be treated again. Any medications known to cause erectile dysfunction? I think the biggest one would be antihypertensives or blood pressure. And that's because when you think about it, your heart is generating a pressure wave. It's generating the blood flow that's going throughout our bodies. If you have a blockage or a narrowing of the blood vessels going to your penis, if you just think of that like a hose, what would you do? You'd try to turn the hose pressure up, right? To try to force the blood to get to the penis. So if you're lowering blood pressure inside of that vessel and you've got a blockage, the end result is you're going to get less blood flow beyond that obstruction to the penis. So the problem is that maintaining your blood flow, or your blood pressure is something that's going to kill you. You're not going to die from erectile dysfunction. So but you could certainly try to talk to your family doctor and say, hey, could we try a different antihypertensive and see if that plays a role? I have an LAD stent. No. So if that an LAD stent just means you have blood vessel disease because you have heart disease. Now, if you're taking nitroglycerin, you couldn't use Viagra if you were using it on a regular basis. If you just said, hey, I carry nitroglycerin, but I never use it, we allow people to take those all the time. But no, you could do shots, perfectly safe. Vacuum devices, perfectly safe. Penile prosthesis, perfectly safe. So really, there would be no issue with any of those treatments other than the use of oral medicines like Viagra if you were taking nitroglycerin consistently. Do P shots work? No. P shots are probably a scam. There's very little data that helps. Basically, what a P shot is where they try to get blood cells. They just take your blood, try to spin it down and get what's called stem cells and then try to inject it. Absolutely no data currently that helps other than the person giving you the shot because they're charging you a lot of money to give it. Are pellets yam-based or synthetic drugs? I don't know the answer to that question. I really don't. All I know is that pellets, typically the brand name is Testapel, and I wouldn't say a lot of patients use pellets, but those that do seem to be pretty satisfied with it, and typically you get pretty good responses in terms of rises in your testosterone. Good. That looks like there's all the questions. And the last slide just gives my information. I have 3 different offices throughout greater Cincinnati. There's a little code that you can scan on your phone there to the right. So we welcome patients coming in. Obviously, this is just a discussion of options. One option is to do nothing, but we like to make sure that you make your decision on reliable and good information. So thanks so much for your time this evening. I appreciate it. And I think we'll go ahead and sign off now. Thanks again.